Well, hey everybody, I'm CJ Brock. Welcome to episode 6 of the Cutting Edge podcast. Happy to be here today. A little bit dreary outside, but definitely bright and cheerful inside. We got an awesome topic today. Great guest to my right, Dr. Keith Smith with Surgery Center of Oklahoma. Dr. Smith, thanks for joining us.
Thanks
to my left, my co-host and partner in crime, Talman with Carrington Advisors. Before we get started, just want to make a few mentions to some folks who help support our show. TexAssist, Surgical Assist Staffing, Carrington Advisors, Moonshot Marketing Group, and Jen Eaton. They're all big parts of making this show happen, and can't thank them enough. You know, one thing that we just want to make sure that we encourage everybody to do as we build our audience and build our content is to follow us on social media as well. We have Facebook and LinkedIn pages, the Cutting Edge Podcast. You can also follow us on Twitter at TCEMedPod. Follow us on Instagram, the Cutting Edge Pod, and subscribe to our YouTube channel. So you get to not only hear our wonderful voices, but see our beautiful faces.
Beautiful faces.
I've always been told I've got a perfect face for radio.
God, thank God it's a dreary day. It's maybe to make us look a little bit better. It's Byron Nelson week, so it has to be a dreary week. That's just the way it is. And then the sun comes out. So
much better that they're playing at Craig Ranch, TPC
Absolutely.
Craig Ranch, because it's not going to be a complete mud pit like it would be at either Trinity Forest or TPC Four Seasons.
Yeah, I'm okay with the folks at Trinity Forest not liking me, but terrible venue. So glad we're at Craig Ranch.
Yeah, well, we're going to stay away from that for the moment. We'll come back. We'll circle back at the end. So our topic for today is pricing transparency in healthcare. It is a hot button topic. Has been for a while. As some of our guests who are listening in know, some don't. Our federal government passed a law that now requires hospitals to publish their prices for all of their procedures. Lo and behold, what has happened? It ain't very easy to find that information online. They may be publishing it, but they have made sure it is not easy to find because that is a very touchy subject. But what's really cool is Dr. Smith's joining us today to talk about the opposite end of that spectrum, which is, you want to know what it costs to have a procedure? Click here, which is the basis of Surgery Center of Oklahoma. So
That's right.
Dr. Smith, again, thanks for joining us, and let's dive right in. So you'll tell us a little bit about you before we kind of get into the topic and kind of your background and how you've gotten into medicine.
Well, I'm an anesthesiologist and did a fellowship in pediatric and cardiac anesthesia and went to Oklahoma City to start my practice. And I think I was very interested and attracted to medicine because the exchange there I knew could be mutually beneficial. I didn't like the idea of making a living and whoever bought my services wasn't happy or felt like it wasn't a value, like they had a gun to their head. And all the physicians I knew, their patients loved them, they worshiped them, and so it was an opportunity, as I saw it, to provide a service and have a happy customer, if you will.
Yeah.
And have a very rewarding and interesting life. I had a chance to be a musician, and I decided not to do that. And so my thoughts going into medicine were basically formed by the golden rule. You know, you treat others like you want to be treated, and that's kind of been my guide, and it's what's led me, I think, to do what we did at the Surgery Center in 2009. So I started my anesthesia practice in Oklahoma City in 1990, and I was very, very busy, doing very well, but I noticed that every year the insurance companies would ratchet back what they were paying me. Medicare instituted some real draconian cuts in 1992 and then again in 1993. And all the while, the physicians were being paid less and the nurses were being paid less and laid off. these hospitals just seemed to grow. There was a crane in front of everyone building on, and the administrative staff blew up, and they were making a lot of money, and patients were complaining about these bills that they were receiving from these hospitals that supposedly were going broke, having a hard time. And I just didn't want to be a part of that. I felt like an accomplice. I felt like an accessory to a crime. Whenever a patient had surgery, I was part of the hospital bankrupting them, basically for procedures I knew didn't cost much money to perform.
Interesting.
And so in 1997, I just quit. I quit practicing at the hospitals and opened up a facility that Steve Lantier and other anesthesiologists and I managed to purchase on a hunting trip, of all things. So,
wow.
So yeah,
that's a heck of a story.
That's how we started.
What kind of hunting trip?
Yeah.
What were you hunting?
We were hunting pheasant and quail.
Pheasant and quail.
And we got a surgery center.
Yeah.
Where were you hunting pheasant at? Just out of curiosity.
Just south of Ponca City, Oklahoma.
Okay. Cool. We go on an annual pheasant hunting trip every year in Tipton, Kansas. So I'm always interested in talking pheasant, but that's completely off topic.
So, anesthesiologists buying a surgery center is great, but you got to have surgeons, right? So how'd you go about, building? My assumption is that you went down this pathway of saying, okay, we're going to contract with insurance. We're going to go recruit physicians and surgeons to be partners with us to bring procedures, kind of the traditional method. Is that how things initially started?
That's what was in our head. Dr. Lantier and I both had great relationships with 12 or 15 surgeons. And when we quit working at the hospitals and opened the surgery center, those surgeons went with us. So they followed us to Surgery Center of Oklahoma and got started. And we did. We thought, these insurance companies are going to love us. We're going to be high quality and reasonably priced. Our thinking when we opened was that we would always tell patients what they were going to have to pay us, because that was a real problem in the big hospitals. And so we told people over the phone, every single patient that we took care of, this is what you're going to owe us, whether they had insurance or not.
Well, that's interesting, because that's still a problem today, right? It's hard for institutions to tell patients, this is what you owe. So, which blows my mind.
So the conversation that you're having with these surgeons and doctors to come in and fulfill this role under what seems like a kind of a new approach, what did that conversation look like? I mean, to me, knowing what I know now, but I mean, we're talking, 15 years ago, knowing what I know now, it's a fairly easy conversation if you've got the volume, because they just cut out all the red tape. They know exactly what they're going to get paid when they go into a surgery and or a procedure versus all of the red tape they've got to go through now. But what did that look like back then? Because I'm sure that was a big leap for them. That's a nerve-wracking place to go if they don't know if they've got, built-in business.
Yeah, and I would argue that it's still a huge leap for some surgeons.
Why is that?
There is this culture of uncertainty and fear that I think is a real undercurrent amongst physicians right now. There's a lot of uncertainty. They're physicians as a group. Nobody feels sorry for them, but that doesn't mean they're not abused by the federal government and the insurance carriers and the hospitals. So, physicians are being beat down in a lot of ways. There's a lot of burnout, a lot of unhappy doctors. And so even now, I think it's a bit of a leap. And doctors now, even surgeons, they many times have no idea what they're going to be paid by an insurance carrier for a surgery. So they know a little bit better than they used to. But you are right in that the early conversations I had were very interesting, because when I decided to post all of our prices online in 2009, I mean, I knew the patient was going to want to know, how much is this? Not how much just is the facility. They wanted to know how much. I mean, they want to write a check and be done, and not write 10 checks or 4 checks. So I met with the surgeons and I said, how much do you think you ought to be paid for a tonsillectomy? They had no idea. They had really no clue.
How is that? How is that possible, right? I mean,
no clue. And I told him, I said, well, pick a number. I'll pick one for you. I thought you were tired of somebody telling you what you were worth. Pick a number. And so it was kind of a homework assignment. And every surgeon I worked with a couple of exceptions, had no clue what they were paid or what they thought was fair to be paid for any of the procedures that you see on our website now. Part of that is not their fault. Part of that, in 1992, the fools at Harvard decided to launch this resource-based relative value scale, RBRVS. Basically, they thought they knew what every single physician service offered was worth. And they were wrong. Whenever you impose prices on a marketplace, those prices are always wrong. They're either too high or they're too low. And if the price is too high, you get a whole bunch of whatever you stuck a high price on. And if the price is too low, you get shortages. So physicians just step back and let the government tell them what they were worth, what choice did they have. And then the networks and the carriers followed suit. So doctors pretty quickly got out of practice of figuring out, this is what I need to charge for this, what the market will bear, what is fair, how I can look this patient in the eye with a straight face and say, for your gallbladder removal, this is what I think, an exchange that's mutually beneficial. Always being sensitive to the patient's inability to pay for whatever reason. So yeah, the conversations I had at the beginning were radical and revolutionary. You're right.
It's so interesting. I mean, I know we're probably going to fast forward to where we are and what you've built now, and I think about any business owner that's building a practice, and oftentimes you're having a discussion around what your services are worth, but who really ultimately determines that? To me, it ultimately comes down to the customer and what value that you're truly providing the customer.
That's right.
Where one person might charge you $1,000 for a particular service, and another person might charge you $3,000 for that service, and the customer might get a better experience with the $3,000 person or the $1,000 person. It really depends on the experience, right? So I'm really curious about, here you are, you've built this practice up. What is the experience that you're trying to create for the end user when they come in, and when they walk away, what do they say about the surgery center and what you've created? What does that look like?
Well, you're exactly right. The consumer, the buyer, is the one that really determines what is value, and prices are just signals that you send into the marketplace, and you declare your worth, and then you hope someone agrees with you. Mm-hmm. So we felt like we needed to send that signal into the marketplace, and we also knew there were other signals being sent out that were multiples of what we were going to send out. For instance, not-for-profit hospitals, so-called not-for-profit hospitals, charge many times 10 times what we have listed on our website. And that those signals are sent into the marketplace. And so, our signal's very powerful at half or a third or 10th of what people are traditionally charged. Our goal when we opened was to provide the highest quality care that was possible at a price people could afford, at a very reasonable price. And if we couldn't do it, we were just going to shut down and close. But we found early on that we could provide the highest quality care at a low price. We found that early on. I was quoting prices over the phone the first week we were open. We had a patient call, and she had a breast mass, and she wanted to know, how much will it cost for this to come out? I thought it's remarkable that someone would actually ask that question, but I was real happy because, that's why we opened. It was pretty cool. Yeah. And as an anesthesiologist, I basically billed for my time. I knew this was going to take 20 or 30 minutes. I called the surgeon and asked him how much he wanted. He had no idea. And I told him pick a number. He said $500. And I hung up on him before he changed his mind because I thought that was pretty cheap.
Yeah.
20 or 30 minutes in the operating room, I made a wild guess at what it actually would cost me in an operating room to have to do a 30-minute case. And I added those three things up. And I was about to take her off hold when I realized she's going to want to know if she has cancer. So I called a pathologist friend and I said, how much to read this breast mass? How much for you to look at this specimen? He didn't have any idea. I said, well, just pick a number. This lady's still on hold. She's going to hang up. $28. So I took her off hold and I said, it's $1,900. And she said, for what? I said, for everything. And she said, well, it's $19,000 down the street at the hospital. That's everything.
Do you have a lot of enemies?
Oh,
I mean, how many physicians said, Doc, you're just flat nuts. Like, well, this is never going to work.
Well, I mean, you've got a guy down the street that's creating this. It has this system where he's providing this incredible value for people, and ultimately, you're just undercutting the whole market and eliminating insurance companies altogether. So I can't imagine that.
Well, you know what I think of, Tyler?
What?
I think Southwest Airlines. When I hear what he's talking about,
there's a lot of similarities.
Yeah,
tremendous value.
You still go from point A to point B. Right. You still have very nice stewardess. You have qualified pilots.
Better. I'd argue better.
Better.
So my friend Jeff Rice, who founded Healthcare Blue Book, he and I met in Austin. I didn't know him at the time, but I made the case that in a functional market, you can sort of claim you get what you pay for. But in a dysfunctional market, you can't make that claim. And I argued that actually the lower the price of a medical service, in all likelihood, the higher the quality. Because the people that have lower prices, that lower prices just means there's competition going on. High prices means you have a cartel running things, and there's no competition, and the big hospitals get all the business whether they're good or not. As prices start to fall, that's an indication that there's competition and somebody's in there mixing it up. And they can't just mix it up on price. They have to mix it up. They have to really know what they're doing. And if your prices are low, there's this crazy bright light on you. Are you any good? At that price, can you possibly be any good? And I'd encourage anybody to look at our Facebook reviews. There are not very many businesses anywhere that have reviews like we have, much less medical businesses. But it's a second to none, just first class experience. And patients they come in disbelief and they walk out just shaking their head. They cannot believe that the exchange was as mutually beneficial as it was. Yeah.
How big is your facility in Oklahoma?
It's about 32,000 square feet. So it's a large surgery center as surgery centers go. We have 7 ORs. We do total knees and total hips and cochlear implants and big procedures. So it's a fairly large facility.
And how many physicians and surgeons, like what's the staff level there, just out of curiosity?
There are 115 surgeons on the staff now. So
that's enormous for a surgery center.
Yeah.
By the way.
In the old days, I used to have to call around, and because we'd have a patient call and they would require a procedure, and we didn't have the surgeon that could do that, or the staff or the equipment. And so I'd go call, a great surgeon and say, hey, are you interested in doing cases over here? And then they would come over and tell us this is what we need to do it. And I mean, that's kind of how we started to build. Now I'm contacted because essentially our model, my friend Jack Brown in Oregon has told me the right word for our model, it's disintermediated. I mean, the physicians own the facility. And by virtue of that arrangement, we've eliminated the most greedy profit seeker from the equation, and that's the institution. No, the hospital.
Oh, really? Okay.
Yeah, so if the docs own the facility and a patient says, I've got this price gouging hospital bill, what can you do about it? the surgeon can't say, I can't do anything about it if he owns the facility. So basically, we've disintermediated the whole system. So we can not even charge at all for the facility if we want. But what we've done is figure out what our costs are and add a marginal profit that's reasonable, and then make sure those who are actually taking care of the patients, the nurses, anesthesia staff, the surgeons, are paid very, very well. And the patients feel that. It's a real red carpet experience.
So let me, I have to summarize this because this is really amazing. We have a doctor on the air with us right now with a 32,000 square foot facility with 115 surgeons on staff that accepts no insurance.
Correct.
And when you walk into his facility, they tell you exactly how much you're going to pay, get the procedure done, hand him a credit card, a check, cash, whatever, and you walk right out the door. Is that not correct?
Well, we also take, we've accepted gold bars and Bitcoin.
Yeah.
You're kidding.
And Litecoin. So,
wow.
Not to pick on any of the cryptos in particular, but yeah, I mean, and you don't even have to ask. It's all on a website. So you can go to our website and click on an area of the body, and there's a drop down, and whatever procedure you've been told you require, there's a price, and that's the price. So
where did peel this onion back a minute, right? So you built a tremendous organization to date. We're 12 years later. But where did you start? What were your core procedures or core specialties that you served when you said, "Hey, we're going to go do this"? Because I guarantee you, there's going to be physicians that are going to come and pick this up, and they're going to listen to this and go, "Man, that's a great idea," but I have no earthly idea where to start.
We started with orthopedics, podiatry, ear, nose, and throat, and pediatric ophthalmology. That's what we started with. We very quickly added ear, nose, and throat, and then urology, and you can go on our website. Everything is oral, maxillofacial, reconstructive surgery. So we do some spine stuff, not a lot, but we do some spine surgery.
How many surgeries a year do you estimate that your facility performs?
Prior to the COVID mess, we would do about 7,000 procedures a year. Wow. We actually had one insurance contract, and it's not really an insurance contract. It was the state employees, and that was kind of a special deal. And then the state government came in and under the pressure of the big hospital systems and made the deal no longer mutually beneficial. So we did what we always do. We fired them. And so our volume dropped back to, between 450 cases a month, something like that. But we don't accept money from the federal government. We never have. We have Medicare patients come in, but they pay us or we don't charge them. But we don't take money from the government, no insurance companies. The people that buy from us are cost-sharing ministries, people that have no insurance, or self-funded health plans. We also have people that have insurance, but they find that the price for their procedure at our facility is less than their deductible. So
walk me through that. Let's take like a Christian healthcare network, Medishare. They're using PHCH or PHCS. And when you say they buy from you, what do you mean by that?
Medishare, and they'll use PHCS as kind of a safety net, but Medishare loves our facility because our prices are so low that PHCS is never even involved.
Okay, so they don't even process it through PHCS.
Correct.
They just say, "Hey, we're just going to write the check and we're done."
We invoice them after the surgery and they pay us.
That's terrific.
And Samaritan works a little bit differently. Christian Healthcare Ministries and Liberty Share work a little bit differently. But we work with all of them. They love us. I think we're actually on the website of Samaritan Ministries. They don't want people to go anywhere else.
So I'm gonna ask a question, because the psychology of this, right? Because this is such a radical departure from our traditional healthcare delivery system. Why, Dr. Smith? Why do you think we don't see this more, where surgery centers, especially outpatient surgery centers, are just more upfront about their pricing, and they pop it right there on their website and they give it to you because you've given everybody the blueprint, right? I mean, it's out there for everybody to see. I mean, the question to me is why? Like, it seems like a no-brainer.
Well, the good news is more and more are. I think I've got my finger on the pulse better than most, but the Free Market Medical Association is this gathering of like minds, and that organization's growing. And I'll plug our annual meeting because it's in Plano in August, and Steve Forbes is the keynote. Ron Paul was keynote 2 years ago when we last had it. It's a large organization, and it's growing, and more people are being straightforward with their prices. So that's the really good news. The reason it's not more prevalent is that these carriers, these networks, they call them the BUCAs, Blue United Cigna Aetna.
That's right.
They most of the surgery centers and hospitals have contracts, unlike me, with these insurance carriers, and they're afraid to show pricing that differs from that in the contract that they have with the carrier. Some of the carrier contracts, I've been told, specifically prohibit providing any kind of service for an amount less than what their contract states. So fear of the carriers, fear of the networks is one of the main hurdles that would have to be overcome for this to be more widespread. But I'll tell you, there are a lot of places that under just very cloak secretly are making these deals because patients all the time will find a price and they'll go to their local price gouging hospital and tell them, you match this or I'm flying to any number of these places that will give me the price. And they typically do match it because that's very creepy for a big, powerful hospital system to let something like that get started. They just can't let that get out of control.
Yeah.
If you don't mind, I want to share a story that I think really hit home here. One of my tax partners, he said something to me a couple of years ago that I thought was really poignant at the time. And he said, the only way that we're ever going to get anywhere with our healthcare is that the consumer, the patient, has got to take control of their healthcare decisions. Because how often do we go into a doctor's office with a sore throat and the next thing we know, they've done 5 or 6 different tests that were completely irrelevant. We didn't even need any of them so that they can bill it out. And so you fast forward a little bit, and my wife and I were going through a tough time with a pregnancy that was not going well. And so we were having to go to a fetal medicine specialist every 2 weeks. I told CJ about this. It was amazing. And every time we go, it was a very big bill. And we're actually on MediShare, and they were processing this through PHCS. When it was all said and done, there was about $11,000 worth of bills that were owed for all of these trips that we went. And the light went off. Ding! You take control of your healthcare. And so I walked into their office and I said, what would it look like if I was just a cash payer? And they said, well, let us figure that up and we'll call you back. So long story short, they reversed all of that out of PHCS and said, if you'll write us a check for $1,800, the conversation's over. And so that's what I did, from $11,000 to $1,800. And that just shows you the amount of red tape that these doctors are going through to simply get the price that they need just to keep their facility open and do good work. This is, by the way, incredible fetal medicine specialist in Dallas, one of the top.
Okay. So
that is just, I was using that as an example of why what you're doing is so great and how I really relate to it.
So this brings up an interesting question. We're talking about facilities posting this information. Where does this take us with physicians, especially private practice guys, right? I mean, employed physicians have no control, but private practice guys certainly have the ability to say, this is what I'm worth, and this is what it costs to come see me, and start to extract themselves from the insurance entanglement.
And you're seeing some of that. The direct primary care movement is a great example of that. And And people pay $80 or $90 a month and have unlimited access to a primary care doc. There are some allergists and ear, nose, and throat doctors that are putting their allergy prices on websites. But again, they have to be pretty careful if they have carrier contracts.
Right.
No one really cares what the general surgeon is going to charge them for their gallbladder surgery.
Because they need it out.
Well, because it's not very much. It's a small percentage of the total bill.
True.
The part that matters, the real price gouging potential, is at the institutional level.
Okay.
And that was the conclusion Dr. Lantier and I came to in 1997, is that if we don't have ownership and control, complete control of the institution, we don't have control over quality, we don't have control over the staff, we don't have control over the bills to which patients are exposed. And so the institutional component is where the primary price gouging potential comes from. So, the physician charges, everybody's, these doctors make a lot of money. The doctors, some of them do make a lot of money, but I'll tell you what, the hospitals are making a killing. So anyhow, that's
so is that maybe the struggle, is that it's such a leap for the physician to dive off? They either have to go, you have to either be a purist or you're not. You've either got to be in the cash pay space, because if not, then you're potentially putting at risk your carriers contracts that you have, or you've got to just kind of continue to just get beat over the head with the insurance side. So I think that's one of the challenges. It's such a leap to go, I'm done today and I'm going to go cash pay. Is that not true?
Yeah, but the good news too is there's some sort of hybrid approaches that I've seen emerging in the country, where physicians or facilities will continue to work with insurance companies, but they're also showing prices, sometimes through a proxy. Sometimes they'll show their prices through an intermediary. I actually display prices for physicians and facilities that are afraid to price them on a website I control called atlasbillingcompany.com. There's another one, the Free Market Medical Association has a tab called Shop Health, and there's a lot of pricing there that people can find. And some of these are not purist unicorns like me that just tell all the carriers to go away. Some of these are hybrid practices that have, deal with insurance companies and don't. And I'll tell you, the executive order, the challenge to the hospitals to show their prices, that was incredibly disruptive. It completely changed the narrative. And the hospitals are fighting back, and they may never show their prices, but the one thing it did is it made those of us with the tinfoil hat on that have been showing prices look a whole lot less weird.
Yeah.
And the folks who are not showing prices, it made them look like they were hiding something, which they are. And so the narrative is completely changed. It's a much more healthy discussion.
Yeah.
And instead of, well, what's wrong with you? You're telling me how much this is. Now it's, what's wrong with you? You won't tell me how much this is.
Well, you said something really interesting as we're preparing for this podcast, in that your facility offers to assist the patient in filing a claim with their insurance company to see if their insurance company will in fact pay anything for services rendered. Right? So it's not, just throw your hands up in the eye of insurance, but I have a high deductible plan and I just have to spend it out of pocket and I have no chance of getting anything. There's actually a possibility that as a service to the patient, you'll say, hey, let us help you with that. Well, we're not going to do an assignment of benefits, so we don't take it, right? We don't get the check. You get the check. And sometimes the patient comes out smelling like a rose on that.
Yeah,
because the insurance company spits a check that's bigger than what they paid out of pocket.
That's right. Because it was a win for the insurance company versus going the traditional route, right?
Well, they just made a mistake.
Yeah.
No, it's the insurance companies don't like Surgery Center of Oklahoma. They don't like anybody that is reasonably priced. They make more money if the initial charge is high because they charge for the discounts they can achieve. And they skim on the discounts. And the self-funded employers are the ones most brutalized by this repricing of claims, because The insurance carriers that administer a lot of these self-funded health plans, they carve out commissions on the discounts that they can achieve. And these discounts are all fictitious. I mean, the self-funded employers would just buy directly from someone providing the service. They don't need the insurance companies on board skimming off of these transactions.
Interesting. I mean, so, if you had words of wisdom, let's take a couple different groups here as we start to wind down our time. If you had words of wisdom to your fellow colleagues, your physician colleagues that are sitting on the fence and they're going, something has to change. I'm going to go bankrupt. I'm going to quit. I got to make a decision. What would be those words of wisdom to them today?
I think the first thing a physician has to do who's miserable and burnout and hates it is to identify where they're leveraged. I think that we have systematically removed leverage from our practices. And I think that is what is so awful, is when you feel like the insurance company or the government is telling you what you can prescribe for this patient or what you can do, or they're telling you this is what we're going to pay you, and it's not fair. It's not. I mean, just give you an example. The last open heart surgery for which I gave an anesthetic in 1993, I was paid $285, and it was 6 hours long.
Oh my gosh.
There's no person that would tell you that's a mutually beneficial exchange. That kind of stuff is still going on.
Yeah.
So the physicians just need to identify very honestly, where am I leveraged? Who is controlling me? Who am I scared of? I mean, who do I feel like I have to tiptoe around? And just start very slowly, not in a drastic way, but in a gradual way, get rid of all those influences in the practice. We don't take federal money, so we don't have electronic medical records in my facility. Physicians hate medical records that are electronic for the most part. For the most part, and they have their place, but the market did not decide what electronic medical records make sense. The federal government did, and they shoved it down everyone's throat. So we have this weird, we have all these electronic medical records that everyone hates, when we could have some medical records that are electronic that had to compete with each other and be the best. So there are a lot of things physicians can do. They need to give some thought to really declaring their worth in the marketplace. Give some thought to, what are these services worth that I'm providing? And maybe even think about launching a website and saying, here, I can't control this facility where I work, but here is what I charge, for an office visit, or, whatever you want to put online. And then if you're a surgeon or a procedure type person, then work hard at the facility where you work to not only get in the game and control the quality of the medical experience, but get in the game to help control the quality of the financial experience for the patient. One of my partners, Chris Paskowski, ear, nose, and throat surgeon, says we cannot claim to be patients' medical advocates when we're bankrupting them, and an accessory to the crime. So, doctors need to be part of a facility, whether they're an owner or whether they're just banging on the door saying, we've got to think about the patient's finances. And it's the right thing to do. And it's also a very profitable thing to do because it really doesn't cost that much to provide this care, not nearly as much as people would think.
Right. Okay, so let's pivot for a moment. You're talking to the benefits administrator for a self-funded employer, right? And they're pulling their hair out. They're looking at this out of control expenditure over the last 5 to 10 years, and they're trying to plug the holes in the dam. They don't have any fingers left. What do you say to them? What are your words of wisdom to them?
Well, if they are a self-funded company and they have a lot of trouble, then they probably need to look around and find another consultant or broker, because these solutions are out there. There's The Health Rosetta is a large group of brokers and consultants. Dave Chase is kind of at the forefront of that. David Contorno, people should watch some of his YouTube videos and get an idea of, what is the broker and the consultant who's actually working for the client, or are they really paid by one of the carriers and they're kind of working for them? Yeah. So if a self-funded employer is, as Jay Kempton says, red-pilled, they're now awake, and they now are acknowledging that we spend too much money on this medical benefit and we're really not getting anything for it, and all we're doing is jacking up the employee's contribution every year. Everyone hates this. Have I been lied to? Have somebody given me some Kool-Aid I shouldn't have drunk? And so if an employer is awake, then they're going to start looking for different advice. But there are so many self-funded companies out there. There are many in Dallas that are buying directly. They have an independent third-party administrator that actually works for them and not for one of the carriers. When I say works for the carriers, if you're paid by one of the carriers and you're a broker or consultant, then you're conflicted. You're grossly conflicted because the interest of the carrier and the client are diametrically opposed. So I hope more and more self-funded employers are red-pilled and kind of wake up and realize, the Free Market Medical Association is there with many, many resources for them and can get them through this.
Great. So last stakeholder here is the consumer, the patient. If you had to provide some words of wisdom to the patient or the employee, what do you tell them today?
I think for the employee to realize that this proxy buyer on their behalf, if it's a self-funded health plan, can really be powerful. And there's no reason they shouldn't be banging on the door of HR, asking them, why aren't we doing what XYZ companies are doing? If you're an individual, just never, ever be afraid to ask how much. Mm-hmm. And if you don't get an answer, move on and just keep asking. And there are many resources online where you can find out how much people are charging for services. Don't be afraid to travel. We take care of patients from foreign countries and all 50 states. And I think people are less afraid to travel for medical services. People go to MD Anderson from all over the world. People go to Cleveland Clinic from all over the world. So
that's absolutely true.
Yeah, they travel to have your procedure, your surgery.
I mean, Tyler, this has been a fantastic session. I mean, we've talked for north of 40 minutes, and it's been so informative for me as not just a healthcare professional, but as a consumer as well, right? Because I think about some of my personal experiences,
absolutely,
and some of the shocking statements that we've gotten, whether it's been childbirth or elective surgeries or whatever the case may be. So, man, I'm so thankful that there's somebody like you and folks in your arena that are fighting for the consumer, that are fighting for transparency, because it is sorely needed. There's no doubt.
It's huge. It's really huge.
Yeah, I mean, I think we're just
true advocacy. Right? I think is the key, and it's refreshing to hear what you guys are doing and having incredible success with a lot of volume, a lot of 7,000 surgeries a year. That's a lot. So,
yeah, I mean,
that's a lot.
That is a lot of. There's a lot of activity going on at that place. I'd love to come and visit sometime.
Yeah, you do it.
Yeah, come check it out. So, talking about exciting times and things, we got the Byron Nelson in town this week. Starts up tomorrow, round 1, bright and early tomorrow morning.
Sun's supposed to come out, 73 degrees. I'm going to be on the course reporting tomorrow afternoon.
You are?
I am. I'm going to follow Jordan Spieth and Will Zalatoris and Scotty Scheffler. I'm not really reporting, but I am going to go watch them play.
Probably drink a couple beers.
Yeah, I might have a beer or two tomorrow afternoon. I mean, that would make my commentary even better. But
absolutely,
no, it's going to be one of the strongest Byron Nelson fields we've seen in a long time.
Absolutely.
Dustin had to drop out today, which was a little unfortunate.
No, but I heard a comment from Brooks Koepka about, man, the golf course is long, the ball's not rolling much. When Kepka says the golf course is long, the golf course is long. So I think that's
wind's going to blow a little. Welcome to Texas, Brooks.
Yeah, that's right. Yeah. I think it's going to be a lot of fun. I really enjoy that venue. It's great for spectating too. There's a lot of places you can see multiple shots. It's going to be a refreshing.
Were you telling me that they're going to try to mimic the 16th at Waste Management?
Are. So it's only partially enclosed. 17, which is about 155-yard par 3 at TPC Craig Ranch, is only partially enclosed this year. But the plan with the salesmanship club is to fully enclose it, 360-degree enclosure next year, and mimic 16 at TPC Scottsdale, and then turn it into a huge party.
I've played that golf course so many times, and to me, I want to look at it tomorrow because there's not that much space there. So
it's going to be tight.
But it's going to feel like you're in a basketball arena trying to hit a golf shot, which is kind of cool.
Yeah. Should be a lot of fun. So for us, all of us golf nuts that live here in Dallas, this is a fun week because it's the circus comes to town once a year, as they say, and it is the PGA Tour is a circus for guys that subscribe and like to go on site. But 10,000 fans will be allowed in every day.
10,000 a day. That I was talking to one of the members out there and said the PGA Tour put a lot of money into this venue and are really excited about the partnership. So such a great event, and it's one of the top 5 or 10 tournaments in the whole and the whole tour that raises the most money for charity, and that's really cool.
It is, in fact, the Byron Nelson has raised more money over its history than any other PGA Tour event on the schedule.
That is correct.
So from a charitable contribution perspective, it has a huge impact on our community, and we ask that everybody that's listening to this, if you live in the DFW area, find a way to support it.
Yeah.
Right? Because it does. There's a lot of folks that benefit from that event, and it's awesome. So again, thanks everybody for joining us. Find us on YouTube, find us on LinkedIn, find us on Facebook, Twitter, and Instagram. We'll have this episode posted soon. And Dr. Smith, thanks for driving down from the Oklahoma City area and joining us, man.
Thanks for having me.
This was awesome. Yeah. So look forward to next week when we have the president of Texas Health Resources Frisco and his chief medical officer talking about public-private partnerships and how the UT Southwestern Texas Health Hospital partnership formed.
Oh, that's where I'm just going to fog over again.
Probably.
It's getting really complex. So.
Well, that's why you're the average Joe.
I'm the average Joe.
Okay. All right, guys. Have a good day. Care.